Welcome back to the channel. When should you get a second opinion, and what about these big name centers that provide second opinions? I want to give some thoughts on this topic. This is all based on a post I wrote on Vinay Prasad's observations and thoughts. That's my Substack, and you should check it out because that's where I put all of the ideas I have in real time, and then only later, if I get the time, I make a video. Second opinions. I think many people with cancer and even other diagnoses benefit from second opinions. It's a good thing to get, but I also think too much of a good thing can be quite bad. And some of these centers that claim to be expert centers, and some of these people who claim to be experts are no such thing, and they're making dishonest claims under the guise of expertise. So the first thing I'd say is, if you have a new diagnosis of cancer, that's really a very important moment where you should get a few things in your own back pocket. One is you should get access to all the copies of the imaging reports, what the radiologist said they saw on the scan. In addition to that, I think it's really good for the patient, for you, to have a copy of the image data itself. Either that's transferred through an internet portal or it's a CD-ROM back in the day, but you need a copy or access to the actual imaging results. The pathology reports, when they did a biopsy, when they looked in the bone marrow, when they did flow cytometry in the blood, what did they find? A copy of that report is invaluable. And the most valuable thing is, of course, your story, how you felt along the way, what happened along the way as they made the diagnosis. I think in the initial diagnostic setting, if there's anything at all unusual about the pathology report or any pauses along the way or anyone who's hinting that there's some doubt, I think a second opinion is well warranted. One is you should get the pathology looked at by a second person, a different pathologist. You should get a different doctor to say, here's my general strategy or approach. Should you get the doctor who's associated with the top cancer centers, the Dana-Farber Center in Boston, Memorial Sloan Kettering in New York City, MD Anderson, or Mayo Clinic? And the answer to that question is no. There's nothing about those doctors that's actually any better. This ranking system was created through the U.S. News & World Report. It has never shown, and it has no correlation with actually providing good clinical care. We showed a couple years ago in an analysis that my team performed is that the U.S. News & World Report rankings, they tend to correlate with the number of ongoing clinical trials an institution has. That's a marker of, are they running pharmaceutical industry studies? That's a marker of, are they going to publish a lot of research papers? That has nothing to do with providing good clinical care. So I do not put any more stock in a Mayo Clinic doctor's opinion than a doctor from Wyoming, for instance. What I want to see is thoughtful reasoning and explanations in the note. And that can be done by many community doctors, it can be done by an expert. So if you have cancer, it might be fine to just get the second opinion from a doctor in a town one over, a doctor at the local university hospital, a doctor who just happens to be someone who took care of your aunt or uncle. It doesn't have to be one of these so-called experts. As long as that doctor feels like it's a second, it feels like they are equipped enough to comment, of course, they should feel that way, and of course they wouldn't comment if they weren't equipped. You just need a second set of eyes on that question. Now, in my essay, I really call these institutions to task. And I think that Mayo Clinic, MD Anderson, Johns Hopkins, Dana-Farber, they're particularly bad because they are making a lot of money from giving second opinions to people who tend to be wealthy, well-connected people. And these people shop around and get opinions from even all 3 or 4 or 5 different centers. And they all have different opinions. You know, I tell the story in the blog about a patient with multiple myeloma. One doctor says, give her Dara-VRD and Velcade Revlimid maintenance and do auto. One doctor says, give her Dara-KRD, no auto, and Dara-Revlimid maintenance. Another person says, give VRD, no auto, Revlimid maintenance. They all have different opinions. And truth be told, if any of them had data that was so persuasive, their opinion was correct, every one of us would be doing the same thing, but they don't. These are different regimens developed with different historical accidents that have never been studied properly against each other. The field of multiple myeloma is notorious that they have 1,000 randomized studies, but they don't even know what's the first thing you should get. They've run 1,000 studies, and they've all tested often trivial questions, and they failed to test the most important head-to-head questions. That's not an accident. That's by design, because the pharmaceutical industry that runs their entire research agenda doesn't want to put Dara-Revlimid Dex against Velcade Revlimid Dex. Boy, Dara might lose and Janssen might lose a lot of money. No, they want Dara-RD versus RD, so they get the win. and they want DARA VRD versus VRD, so they get the win. Only very rarely do you get any trial that seems to be useful at all, KRD versus VRD. They ran that trial by the cooperative group thinking KRD would win, and it blew up in their face. KRD did not win. Some people incorrectly say that trial proves they're equivalent. Those people need to go back to class and learn the difference between a failed superiority study and a non-inferiority or equivalent study. That's not an equivalent study, so that's wrong. Okay. So, what do experts know? Experts often have seen lots of people with the same condition, and they may have some sort of gut feeling that can be useful or helpful. At the same time, experts can also be betrayed. They can have deep relationships with the companies. They can be receiving a lot of money from the companies. They can have dueling incentives. On the one incentive to provide you the best care, on the other incentive is they got to accrue for a trial that they promised BMS they would accrue to. So they might be giving you the recommendation to join their trial that might be not in your best interest, but in the best interest of the sponsoring company. And since I wrote my post, a bunch of oncologists said, you need to do an expose on, and then they said the person's name, because this person is running a whole bunch of, then they used a bunch of expletives, studies on patients who should be getting the standard of care. And then they said, expletive, 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 this person is, etc., a sellout. Okay, I'm not going to say the person, but we've all heard stories like that, and we've all witnessed stories like that when people go to get these different opinions. Now, when I meet a patient who's gotten 5 different opinions, I'm the first person to admit, listen, if any of these doctors knew for sure their opinion was right, then we all would be on the same page. They don't. Here's why. We don't have these sorts of studies. Here's why the course that I've plotted out for you I think is better than their other options. One is, all things being equal, in the absence of proof that a new drug is better and makes you feel better or live longer, I tend to go with drugs that have a proven track record, that have more randomized studies showing survival benefits, and all things being equal, fewer drugs for less amount of time, less toxicity, less time on drug. That's my philosophy, that the burden of proof is on the makers of costly branded pharmaceutical firms to show that their products help when added to our therapies, and not on third parties to be skeptical of it. I saw recently a myeloma expert said patients need Velcade Revlimid maintenance. That to me is so bad. It's a toxic drug, Velcade. It causes neuropathy. There's not a single randomized study that shows Velcade Revlimid maintenance has a survival benefit over Revlimid maintenance. Revlimid has randomized data. Even, you would argue, DARA and Carprolis have randomized data, but Velcade doesn't have randomized data. That's an antiquated, unproven regimen. And really, it's sort of like a doctor, when you're scared and you see something that scares you, just throw more drugs at it. It's not much better than that sort of instinctual base instinct. But the difference between a base instinct and science and medicine is you actually run some controlled studies. They don't want to do that. They just want to change the protocol. I really think that places like Mayo Clinic, MD Anderson, Sloan Kettering, they want to say with one part of their mouth that rankings don't matter, these rankings are all BS, and the other part of the mouth, by the way, we're number 1 in the Northeast or something like that. Let's talk about the rankings. When the U.S. News & World Report ranks these cancer hospitals, that has absolutely nothing to do with the clinical care they provide. They have never created a measure of which hospital provides the best clinical care, and I doubt they're going to do that anytime in the next few years. They've failed miserably. This is a measure of reputation and a whole bunch of other metrics that have little to do with the actual quality of care you get as a patient. We did a study a few years ago where we show a very tight R-squared, which is a coefficient of determination, between the number of ongoing clinical trials and the U.S. News & World Report score. In other words, the reputation largely is driven by places that run a lot of trials. Why? They publish a lot of papers. Other doctors know of them. It doesn't mean they provide any better care. In some cases, they provide worse care because they're so well known. They recruit people from long distances. The people that make it to the center are healthier and wealthier and wiser than the average person. They conduct studies on those people and draw inferences for the average person, which actually, when you give it to someone who's not as fit, who can't tolerate a 14-hour commute to get your therapy, you start to have much worse outcomes than what they experienced on study, and actually perhaps even worse than lesser or cheaper or more aggressive standards of care. I don't put any stock in that at all. Someone recently told me that they have a really good doctor. Their doctor is a professor at University of whatever, something fancy, and that's a good doctor. And I said, why would that be a good doctor? And they say, we have to be a good doctor to become a professor at university of whatever. I said, who told you that? You don't got to be a good doctor to be a professor of university whatever. You just need to be somebody who played a game where you repeatedly cajoled the pharmaceutical industry for many years to give you more trials, and you've created some portfolio of bullshit on your CV, and then you can be a professor at university. It has nothing to do with good clinical care. There are many people who are professors at top institutions who are probably worse than the average clinician. If you threw a dart at a map and just picked the nearest oncologist, you'd have a better odds than some of these professors. Why? Because the doctor you throw the dart at, this is a doctor whose primary focus is caring for patients. They may be more attentive to results than university professors that got 20 other things going on, including some side companies. 2, the doctor in the community might have less financial conflicts of interest with any company than said university professor. Number 3, doctor in community might have more weekly clinical experience taking care of people in hospital settings than this doctor. Number 4, doctor in the community sees other diseases and has some perspective on cancer more broadly that is lost from this super subspecialist. This is not necessarily the case. It could be the subspecialist is better. We just don't know. You just can't take for granted that the professor at university is providing good clinical care. I'm often asked, and I don't often accept, but I'm often asked to look into somebody's care, and then they give me all the reports, all the pathology results, all the scans, and they tell me the story, and I look through the chart. And I'm often mortified by what I see because I see a lot of bad things happen along the way. So, my recommendation is initial diagnosis. If there's any uncertainty at all, get that path reviewed by someone else. Get the second opinion of someone else. It doesn't have to be at a top center. In fact, it might be better. It's just your local doctor one town over, a doctor at the local university. Okay. Then, at other major treatment junctions along the way, 6 months later, 12 months later, get that second opinion a second time. But what you don't want is you don't want 5 opinions right off the bat. You don't want to know what Dana-Farber, Mayo Clinic, MD Anderson, Sloan Kettering all think, because you're going to hear very different recommendations, and you're going to be confused. And ultimately, all those recommendations are going to steal from you the most important thing you have, which is actual trust and confidence in your doctor. You want a doctor you trust. Someone recently tweeted that old sign, "Don't confuse your Google search for my medical degree." And another person, a nurse practitioner, commented saying, "I hate this. It's so condescending." And I agree with the nurse practitioner. I've always hated people who say that. Don't confuse your Google search for my MD. Number one is, if your MD was so great, then how the hell did you get almost every single pandemic policy decision wrong? You're so bright, of course. You got all those wrong. Okay, fine. Second, people who are well educated can often do research and ask very thoughtful questions, and a doctor who's worth their salt will actually take the time to explain why they agree or disagree with what you read online, why they agree or disagree with another doctor. If your doctor doesn't have time for that, maybe you need to find time to have another doctor. I mean, that's really the lesson that comes out of that. So, overall, second opinions, I think, have a small role. Be careful. Too much of a good thing can be quite bad. Don't put any stock in these people who are at the top cancer centers. They often have conflicting motives. They want to recruit for their clinical trial. They want to use one product. Sometimes I've discovered what they're actually doing is they want to build a cohort of people they treat with something that's basically investigational, and only after the fact do a retrospective chart review of those people to demonstrate the validity of that approach. If they wanted to do that, they should do that prospectively with an IRB clearance. But I feel like that's happening, but they're not doing it the right way. Those are my thoughts on second opinion in cancer medicine. I think it's not a bad idea. It's not necessarily necessary. However, it should be done if it's done in moderation. And I'm much more interested in a real second opinion, which means looking at the scans with your own eyes, looking at the path in the pathology room, talking to the pathologist. To me, that's what I like to do when I'm on service. Everyone who's ever worked with me, on my team knows I take them down to radiology and we look at the images ourselves, and we often have a very different picture in our mind than merely the report, which is written by a radiologist who's under legal pressure and is worried about all these other things rather than just giving you the medical information you need. So get a copy of all your scan results, get a copy of all your pathology reports, get a copy of any molecular tests, and keep track of your story. That's the most important thing. That's what really separates, I think, a thoughtful, caring second opinion from just sort of a frivolous glance at the chart. If you like this video, you know what to do. Like, subscribe, comment, leave a message below. I will be back with more videos. There's lots of interesting things to talk about, but I thought I'd talk for a minute about second opinions. Until next time.